Hello students. In today's session, we will be talking about the problem of doctor variability. What is this doctor variability? Well, traditionally, doctors are regarded as having an objective knowledge. If you remember, in the previous sessions that we have had, we have been talking much about this objectivity, an objective knowledge of doctors. And they comes from their extensive medical education. Well, if this were the case, then it could be predicted that the doctors with similar levels of knowledge and training should behave in similar ways. In addition, if the doctor's behavior was objective, then their behavior would be consistent. However, in reality, we find that there is considerable variability among doctors in terms of different aspects of their practice. And let's see a little research which talks about this variability. Anderson and others in 1983 have reported that doctors differ in their diagnosis of asthma. Mapes in 1980 suggested that they vary in terms of their prescribed, with a variation of 15 to 90% of the patients receiving drugs. Bucknell and others in 86 reported variation in the methods used by doctors to measure blood pressure. And Matto and Baum in 1984 have reported that doctors vary in the treatment of diabetes. According to the traditional educational model of doctor-patient communication that we have discussed earlier, this variability could be understood in terms of different levels of knowledge and expertise. However, this variability can also be understood by examining the other factors which may be involved in the clinical decision-making process. How do we explain variability? We are going to look at it from three perspectives. The first and foremost is clinical decision making as problem solving. The second perspective is going to be the role of health professionals' health beliefs, and the third perspective relates to an interaction between health professional and patient. Let us now talk about explaining this variability that we have been discussing with reference to clinical decision making as problem solving. We will discuss a clinical problem solving model. Clinical decision making processes are a specialized form of problem solving, and they have been studied within the context of problem solving as well as theories of information processing. It's often assumed that clinical decisions are made by the process of inductive reasoning, which involves collecting evidence and data and using these data so that they develop a conclusion and hypothesis. For example, within this framework that we have been discussing, a general practitioner would start a consultation with a patient without any prior model of their problem. Then this GP, that is general practitioner, would ask appropriate questions regarding the patient's history and the symptoms, and then develop a hypothesis about what the presenting problem might be, and develops a hypothesis as to what the presenting problem is. However, doctors' decision-making processes are generally considered within the framework of hypothetico-deductive model of decision-making. This perspective, that is this hypothetico-deductive model of decision-making, emphasizes the development of hypothesis early on in the consultation and is illustrated by the model which is presented by Newell and Simon in 1972. It is a model of problem solving which emphasizes hypothesis testing. Newell and Simon suggested that problem solving involves a number of stages that result in a solution to any given problem. This model has been applied in many different forms of problem solving, and it is a useful framework for examining clinical decisions as well. Now let's look at the stages in Newell and Simon's model. The first stage is understanding the nature of the problem and developing an internal representation. At this stage, the individual needs to formulate an internal representation of the problem. As you have noticed in what I have just mentioned, the process involves understanding the goal of the problem, evaluating any given condition, and assessing the nature of the available data. Now, the second stage would be developing a plan of action for solving the problem. Newell and Simon have differentiated between two types of plans which are called heuristics and algorithms. An algorithm is a set of rules which provides a correct solution if applied correctly. For example, addition, multiplication, all these involve algorithms. On the other hand, heuristics, most human problem solving involves heuristic, which refers to a rule of thumb. Heuristics are less definite, they are less specific, but then they do provide guidance and direction towards the problem solved. Heuristics are less definite and less specific, but they provide guidance and useful direction to the problem solver. Heuristics may involve developing parallels between the present problem and previous similar problems. Now, the third stage in this model is applying heuristics. Once the plans are developed, then they are applied to a given situation. Fourth step which follows will be determine whether these heuristics which have been applied have been fruitful. The individual decides whether the heuristics have been successful in the attempt to solve these problems which are there in front of him. If they are considered unsuccessful, then the individual may need to develop a new approach to solving the problem once again. Then the fifth step, which is the next step, is to determine whether an acceptable solution has been obtained. And finally, finish and verify the solution which has been obtained, the end point of the problem solving process. This involves the individual deciding that an acceptable solution to the problem has been reached and this solution provides a suitable outcome. According to Newell and Simon's model of problem solving, hypotheses about causes and solutions to the problem are developed very early in the process. They regarded this process as dynamic, not static, and ever changing, and suggested that at each stage of the process, the individual applies a means end analysis. Now, what is means end analysis? In this process, they assess the value of the hypothesis, which is either accepted or rejected according to the evidence. Now, this type of model involves information processing whereby the individual develops hypothesis to convert an open problem which may be unmanageable with no obvious endpoint, which can be closed and which can be tested by a series of hypotheses. Now, let us apply it to the clinical decision making as problem solving. Clinical decisions can be conceptualized as a form of problem solving in themselves, and they involve the development of hypotheses early on in the consultation process, as we have discussed a little earlier. Now, these hypotheses are subsequently tested by the doctor's selection of questions. Models of problem solving have been applied to clinical decision making by several authors, like for example McVinney 1973, Weinman 1987 and others, who have argued that the process of formulating a clinical decision involves stages which we are going to discuss now. What are those stages in clinical decision making as problem solving? First, accessing information about the patient's symptoms. The initial questions in any consultation from the health professional to the patient will enable the professional to understand the nature of the problem and also to form an internal representation of the type of the problem that the patient has presented. The second is developing hypothesis. Early on in the problem solving process, the health professional develops hypothesis about the possible causes and solutions also to the problem which is presented. The third will be searching for attributes. The health professional will proceed to test the hypothesis by searching for factors either to confirm his hypothesis or refute his hypothesis. Research into this hypothesis testing process that I have just mentioned has indicated that although doctors aim to confirm or refute their hypothesis by asking, they mean to ask balanced questions, most of their questioning is biased towards confirmation of their original hypothesis. An initial hypothesis that the patient has a psychological problem, for example, may cause the doctor to focus on the patient's psychological state and ignore the patient's attempt to talk about their physical problems or symptoms. Studies have shown that doctors' clinical information collected subsequent to the development of the hypothesis by them may be systematically distorted to support their original hypothesis. Now, the fourth step is making a management decision. We have just discussed about the problems with searching for attributes, and making a management decision is the next step, and the outcome of the clinical decision making process involves the health professionals deciding upon the way forward. So, to summarize whatever we have talked so far, variability in the behavior of health professionals can be understood in terms of processes involved in clinical decisions. For example, health professionals may access different information about the patient's symptoms, they may develop different hypotheses, then they may access different attributes either to confirm or refute their hypothesis, and they have different degrees of bias towards the confirmation of whatever hypothesis they have made, and also consequently they reach different management decisions. Let us now explain variability in terms of the role of health professionals' health beliefs. Health professionals' health beliefs is a topic which is being researched very extensively. The hypothesis testing model of clinical decision making provides some understanding of the possible causes of variability in health professional behavior. Perhaps the most important stage in the model that we have discussed that may lead to variability is the development of original hypothesis. If you remember, we have talked extensively about that. Patients are described as having lay beliefs which are individual, which can be variable as well, and health professionals are described as having professional beliefs which are often assumed to be consistent and predictable. However, the development of original hypothesis involves the health professional's own health beliefs, which may vary as much as those of the patient. Now, let's talk about the categories of health beliefs involved in making the original hypothesis. The health professionals' very own beliefs about the nature of clinical problems may be discussed now. They have their own set of beliefs about health and illness. This pre-existing factor of possessing these own health beliefs may influence the choice of their hypothesis. For example, if a health professional believes that health and illness are determined by biomedical factors, like for example lesions, bacteria, virus and others, then they will develop a hypothesis about the patient's problem which reflects in their perspective. For example, a patient who complains about high temperature, body aches, pains and shivering, they may be having a particular type of fever. They will put them under a category of fever. On the other hand, there may be health professionals who view health and illness as relating to psychosocial factors. Then they develop hypotheses reflecting this particular psychosocial perspective. For example, when a patient complains of lack of energy all the time, then it is understood by the professional that he is under stress. The second issue is the health professional's estimate of probability of hypothesis and disease. Health professionals will have pre-existing beliefs about the prevalence and incidence of any given health problem that will influence the process of developing a hypothesis. For example, some doctors may regard childhood asthma as a very common complaint and hypothesize that a child presenting with cough and other symptoms has asthma, while there might be others who believe that childhood asthma is rare, and they do not consider this hypothesis which the other doctors propose. Now, the third aspect is the seriousness and treatability of the disease. Weinman in 87 argued that health professionals are motivated to consider the payoff in reaching a correct diagnosis, and that will influence their choice of hypothesis. He suggested that this payoff is related to their beliefs about the seriousness and treatability of the illness as well. For example, a child presenting with abdominal pain may result in an original hypothesis of appendicitis, as this is both a serious as well as treatable condition, and the benefits of arriving at correct diagnosis for this condition are more than the costs involved. Costs involved are like, for example, wastage of time and all, if this hypothesis is refuted. And Monteau and Baum in 84 have argued that health professionals vary in their perceptions of the seriousness of diabetes, and that these beliefs will influence their recommendations for treatment. Brevin in 84 carried out a study looking at the relationship between medical students' perceptions of the controllability of patients' life events and the hypothetical prescription of antidepressants. The results of this study have shown that the students reported variability in their beliefs about the controllability of life events, and if the patient was seen not to be in control, that is, if the patient is seen as a victim, then the students were more likely to prescribe antidepressants than if they see the patient as to be in control of his life events. This suggests that not only do health professionals report inconsistency and variability in their beliefs, we were talking only about patients, even the health professionals may vary and they may show inconsistency and variability in their beliefs, and this variability may be translated into the variability of their behavior. Then the next aspect is the personal knowledge of the patient. The original hypothesis will also be related to the health professional's existing knowledge about the patient. Such factors may include a knowledge about the patient's medical history, psychological states, an understanding of their psycho-social environment, and a belief about why the patient is using the medical services. In addition to this, there may be the influence of the health professional's stereotypes. Stereotypes are sometimes seen as problematic and as confounding the decision-making process as such. However, most meetings between health professional and the patient are limited in their time. They do not have much time, and consequently stereotypes do play a central role in developing and testing a hypothesis and also reaching a management decision. Stereotypes reflect the process of cognitive economy and may be developed according to a multitude of factors like how the patient looks, how the patient talks, walks, or whether they remind the health professional of previous patients. Without stereotypes, consultation between the health professional and patient would be extremely time consuming. In addition to the factors that we have talked about, there are certain other factors which might influence the development of the original hypothesis that we have been talking about. One of them is the health professional's mood. Surprisingly though, this is indeed true. Eisen and others in 1991 manipulated the mood in a group of medical students and evaluated the effect of induced positive affect on their decision-making processes. Positive effect was induced by informing subjects in the particular group of the students in the group that they had performed in the top 3% of all graduate students nationwide in an anagram task. All subjects were then given hypothetical patients and asked to decide which one was most likely to have lung cancer. The results showed that those subjects in the positive effect, it has been induced, remember, they have spent less time in reaching the correct decision, and they have also shown greater interest in the case histories which is going beyond the assigned task to them. The authors therefore concluded that mood influences the subject's decision making process. One more factor is the profile characteristics of health professional. Factors such as age, sex, weight, geographical location, previous experience, and health professionals' own behavior may also affect the decision making process. For example, smoking doctors have shown to spend more time counseling about smoking than their non-smoking counterparts, according to a study by Stokes and Rigetti. Another study has shown that thinner practice nurses have shown to have different beliefs about obesity and offer different advice to obese patients than overweight practice nurses. Communication of beliefs to the patients is the other aspect that we have to consider now. If health professionals hold their own health related beliefs, these may in turn be communicated to the patients as well. This has particularly been studied in the domain of risk communication. A study by McNeil and others in 1982 has examined the effects of health professionals' language on the patient's choice of hypothetical treatment. They assessed the effect of offering surgery either if it would increase the probability of survival or decrease the probability of death. The results showed that patients are more likely to choose surgery if they believed that there is an increased probability of survival rather than decreased probability of death. Similarly, Senior and others in 2000 have explored the impact of framing risk of heart disease or arthritis as either genetic or unspecified using hypothetical scenario. The results showed that how risk was presented influenced both the participants' rating of how preventable the illness was and their beliefs about causes. Another study by Misselbrook and Armstrong in 2000 asked patients whether they would accept treatment to prevent stroke and presented the effectiveness of treatment in 4 different ways. Although all forms of presentation were actually the same, the ways of presenting the risk has been varying in all these interventions, and this resulted also in the variation in the patient uptake. 92% of the patients who participated in the study said that they would accept treatment if it reduced their chances of stroke by 45%. This is called a relative risk. 75% said they would accept the treatment if it reduced their risk from 1 in 400 to 1 in 700. This is called absolute risk. 71% said that they would accept if the doctor had to treat 35 patients for 25 years to prevent 1 stroke number needed to treat. Only 44% said that they would accept if treatment had a 3% chance of doing them good and a 97% chance of doing no good or not being needed. This is called personal probability of benefit. Harris and Smith in 2005 have carried out a similar study, but they compared absolute risk, which I have pointed out in the earlier study. They compared absolute risk, that is high versus low risk, with comparative risk, which is above average versus below average. They asked participants to read information about deep vein thrombosis, DVT it is called, and to rate a range of beliefs. The results showed that samples were more disturbed by absolute risk. Ogden and others in 2003 have used an experimental design to explore the impact of the type of diagnosis on patients' beliefs about common problems. Patients were asked to read a vignette where they were told that either they had a problem using a medical or diagnostic term, for example tonsillitis, gastroenteritis, or using a lay term, for example sore throat, stomach upset. The results showed that although doctors are often told to use lay terms and layman's language when speaking to the patients, patients actually preferred, according to this study, the medical labels, as it made the symptoms seem more legitimate and gave the patient more confidence in the doctor who is treating the patient. Therefore, if a doctor holds a particular belief about the risk or the nature of a illness, then the chosen language, the language that he chooses, reflects these beliefs, and these beliefs may be communicated to the patient in a way that then influences the patient's own beliefs and the subsequent behavior. Now, we will talk about explaining variability as an interaction between health professional and patient. The explanations of variability in health professionals' behavior, which we have been discussing so far, have focused on health professional in isolation. The educational model, for example, which we have discussed some time back, emphasizes the knowledge of health professional and ignores the factors involved in clinical decision making and their health beliefs. This perspective accepts the traditional divide between lay beliefs as well as the professional beliefs. Emphasizing the clinical decision making processes and health beliefs represents a shift from this perspective and attempts to see a divide between these two types of beliefs as problematic. Health professionals have their own individualized lay beliefs which may be similar to the patient's. However, this explanation of variability ignores another important factor, that is the patient. In order to understand the processes involved in health professional and patient communication, based upon which there are resulting management decisions and any variability in the outcome of the consultation, both the patient as well as the health professional should be considered as a dyad, as a unit together. The consultation involves two individuals and a communication between that exists between these two individuals. There is a shift from a model where the doctor is considered as an expert. From there is a shift towards interaction. So, from expert model to an interaction model, and the emphasis is on patient-centeredness, agreement between health professional and patient, and concerns about informed choice. We will talk about these three aspects a little more in detail now. Number one, it is patient-centeredness. The concept has first been developed by Bain and Long in 1976, and the concept of patient-centeredness has increasingly become in vogue over recent years. The prescriptive literature as a preferred style of doctor-patient communication as a means to improve patient outcomes according to several researchers. Further, Empirical research has explored both the extent to which these consultations can be deemed as patient-centered. For example, there was one classic study by Tuckett and others in 1985 which analyzed recorded consultations and described the interaction between a doctor and a patient as a meeting between experts. Research has also addressed whether patient-centeredness is predictive of outcomes such as patient satisfaction, compliance, and patient health status. Let's look a little more into this, understanding this patient-centeredness. Although varying in operationalizing concept of patient-centeredness, in general the construct is considered to have three central components. What are these components? Number one, a receptiveness by the doctor to the patient's opinions, to the patient's expectations, and an effort to see the illness through the patient's eyes. Number two, patient involvement in the decision making, in the planning of treatment. And the third is the attention towards the affective component, that is consultation in terms of emotions of both the patient as well as the doctor, not just anyone. Now, patient-centeredness is the way in which consultations are supposed to be managed in the present day. It emphasizes negotiation between patient and the doctor and places the interaction between the two as central. That's a central feature over here. In line with this approach, research has explored the relationship between health professional as well as the patient, with an emphasis not either on health professional or on the patient, but as an interaction between these two. There are different ways of looking at this. Number one, it is the level of agreement between health professional and patient, and number two, the impact of this agreement on patient outcome. How does it look at agreement between health professional and patient? What is this agreement between health professional and patient? If health professional and patient communication is seen as an interaction between two individuals, then it is important to understand the extent to which these two individuals speak the same language, share the same beliefs, and agree with each other in terms of the desired content and outcome of any consultation. This is of particular relevance to general practice consultations, where patient and health professional perspectives are more likely to coincide. For example, there was a study by Pendleton and others in 1984 which argued that the central tasks of general practice consultation involved agreement with the patient about the nature of the problem, the action that has to be taken, and also the subsequent management. Tuckett and others in 1985 likewise argued that the consultation should be conceptualized as a meeting between experts and emphasized that the importance of patients and doctors' potentially different viewpoints of the problem. Research has also examined levels of agreement between the general practitioners and patients' beliefs about different health problems. Ogden and others in 1999 have explored the general practitioners and patients' models of depression in terms of symptoms, that is the mood, somatic symptoms, the mood, causes in terms of psychological, medical, and external environmental factors, and treatments which might be medical or non-medical. The results have shown that general practitioners and patients agreed. They have agreed upon the importance of mood-related symptoms, psychological causes, as well as non-medical treatments. However, general practitioners reported greater support for somatic symptoms, medical causes, and medical treatments. Therefore, the results do show that general practitioners hold a more medical model of depression compared to the patients. We see the difference in the perspectives. Ogden, Bandera, and others have explored general practitioners and patients' beliefs about obesity, and yet another study in 2001. The results showed that general practitioners and patients reported similar beliefs for most psychological, behavioral, and social causes of obesity. However, they differed consistently in terms of their beliefs about medical causes. In particular, the patients rated a gland or a hormone problem, and they also slow metabolism and overall medical causes more highly compared to the general practitioners. On the other hand, for the treatment of obesity, a similar pattern emerged with two groups reporting similar beliefs for the range of beliefs, but showing different beliefs about who was most helpful. While patients rated the general practitioner to be more helpful, the general practitioners on the other hand rated the obese patients themselves more highly. Therefore, although general practitioners seem to have more of a medical model of depression, they do seem to have a less medical model of obesity in the two studies that we have compared. Research has shown that doctors and patients differ in their beliefs about certain aspects. For example, the role of the doctor, about the value of the patient-centered consultations, about the very nature of health, about chronic disease and the role of stress, and what is important to know about medicines, and if the health practitioner and patient communication is seen as an interaction, then these studies suggest that it may well be an interaction between two individuals with two different perspectives altogether. However, in spite of this variation, isn't there a role of agreement in terms of patient outcomes? If doctors and patients have two different belief systems about illness, different beliefs about the role of the doctor and medicines which are prescribed, it is possible that this disagreement may result in certain aspects like poor compliance to the medication. For example, the patients may ask, why should I take antidepressants when I am not depressed? Poor compliance to any recommended changes, behavior, why should I eat less if obesity is caused by hormones, may be the question of the patients. Or there may be a low satisfaction with reference to the consultation. The patient may say, I wanted emotional support and what the general practitioner gave me is a prescription. There was one study which examined the extent to which a patient's expectations of a general practitioner consultation were met by the general practitioner and whether this in turn has predicted patient satisfaction. Now finally, we'll talk about informed choice. Gaining informed consent is now a central requirement of any research study or a clinical intervention, and it aims to ensure that the participants have understood what they are about to take part in and any side effects with relation to the study, if at all it might have. Informed consent can be either written or verbal. However, it depends upon the nature of the study. It cannot be common to everything. For gaining ethical approval, and medical councils across the world have stipulated that the patients must be given sufficient information to enable them to consent to participate in a procedure in an informed way. Informed consent that hence refers to a formal process prior to a research or a clinical work. It is generally agreed that informed decision is the one that is made effectively, but whether effectiveness relates to the evaluations of the final choice, which means the outcomes, or the way in which the decision is made, that is the process, is not clear. We will talk further about this outcome and process a little more. Becker in 2003 provides a clear analysis of these two different perspectives that we have been talking about and highlights the theoretical positions that inform the emphasis on outcomes or process. Let's discuss about the outcome first. Becker describes how a choice is effective if the individual has surveyed the decision options, evaluated the consequences of each option in terms of certain aspects. Likelihood, that is the expected probability of consequences occurring, of attractiveness of the outcome of each action, that is the utility, created an expected utility for each option by combining the likelihood of consequences and attractiveness, then choosing the option that has the greatest expected utility. In addition to that, the approach thus emphasizes the outcome of a decision. The problem with this approach then is that most decisions are made in such a rational way. In addition to that, it is possible that even if the individual is rational, it may be based upon inaccurate information. Let's now talk about the process point of view. Becker argues that an effective decision is one that has met three criteria in terms of the process used in order to make the decision. The decision is based on the information about the alternatives and their consequences, the evaluation of the likelihood and desirability of the consequences, and a trade-off between these factors if it is evident. Central to this approach is the role of individuals' own beliefs. O'Connor and O'Brien-Pallas in 1989 take a process approach to informed choice, which we are discussing, but also add an individual's behavior. They describe an effective decision. They describe an effective decision as one which is informed, consistent with the decision maker's values, and then behaviorally implemented. How is informed choice measured? Finally, let us discuss about this. As a means to assess informed choice, Marteau and others in 2001 have developed a new measure of informed choice, which was based upon O'Connor and O'Brien-Paller's definition, which we have just discussed, and included measures of knowledge, attitudes, and behavior. They argue that when these three components are consistent with each other, then the person can be deemed to have made an informed choice. Thank you.